So what we've learned here so far is there's a long pre-symptomatic window in Alzheimer's disease. And remember I said 15 years with no symptoms at the beginning. Opportunity for doing something right and preventing or delaying the game. Your cognitive lifestyle over decades makes a difference. Your tipping point can be moved by years. And as I mentioned, an important clue to future treatment. There's a well-known study that's inspired a lot of other studies internationally. The study is called FINGER. It was done in Finland with not seniors who were experiencing mild cognitive impairment, but they pretty much stacked the deck. They picked people that had the highest risk and had the lower half of the scores on the cognitive tests. And they did this multi-domain intervention where they worked on improving their diet, their exercise, to do cognitive training with them, and to monitor hypertension and other vascular risk factors. And I'm not going to spend a lot of time on it, but you can see all these red and blue curves separate over time, showing that there was better cognitive outcome in the people that were in this treatment group. So even when you're starting to become symptomatic, it's not too late to make these interventions to build resilience to Alzheimer's disease. Okay, so that's sort of like some of the basic information I'd like you to know. In terms of current best practice, these are the things I think we should all be aspiring to as we evaluate and treat people with memory loss and dementia in 2023, and include really starting in primary care with cognitive screening done probably as part of your wellness visit, lifestyle counseling, with a goal to detect and accurately diagnose the process at the mild cognitive impairment stage. I've talked about interventions to leverage strengths in compensation. In our group, we have a program that we have a little boot camp, a 2-week boot camp that will have a couple go through, a patient and either a spouse or an adult child or a good friend, to help reinforce this habit learning kind of strategy that we are using for compensation. We, like many other groups, regarded as standard of care to treat people with the symptomatic medicines like Aricept or Donepezil. We encourage early attention to advanced directives and really try to individualize case management. So that's best practice in 2023. I think we'll talk in a few minutes about going beyond this to start to look at disease-modifying treatment. And so what we're about really is building a positively framed, but still scientifically grounded, forward-looking view of brain health. And some of the big ideas that we're working with are this building resilience to dementia, strength-based reframing, and then what I haven't really talked about is this concept of dementia-friendly community, which is meaning embedding people with memory loss and dementia in a situation where they can live to their potential, okay? Like you would a child, right? Needs some support, but there's a lot to offer. So our program called ADAPT, this is our 2-week boot camp program. We embed ADAPT in our sort of model for dementia-friendly community called the Memory Hub in Seattle in partnership with the Fry Art Museum. If you're interested, I encourage you to go to thememoryhub.org and read a little bit about that. It's a beautiful space. There's a lot of artwork done by our patients in a beautiful memory garden. So in what I think we've done so far is really changed the paradigm for memory evaluation and care. So now instead of encountering people at the 10-yard line, we're encountering them at the stage of mild cognitive impairment pretty routinely. And we're thinking about encouraging through our educational efforts, through the whole lifespan, thinking about these factors that modify your dementia risk, your vascular health, your mental health, sleep, nutrition, exercise, cognitive engagement, with the goal to build cognitive resilience, and once people become symptomatic, to compensate with these strategies by leveraging their retained strengths. And then this idea of dementia-friendly community then is something which is especially important as people become more symptomatic later. We continue to use the symptomatic medication, and we've just started to think about how disease-modifying medication is going to help us. And before I can talk more about that, you need to learn a little bit about my next topic, which is, sorry, I'm clicking one but not the other. Excuse me. There we go. Sorry about that. So before I can tell you more about disease-modifying therapy, you have to know something about biomarkers. So we've talked about amyloid plaques and tau tangles as being the sort of defining hallmarks of Alzheimer's disease. But the proteins that make up these structures, the amyloid protein and the tau protein, can be detected in the spinal fluid, on brain scans, and more recently, as I'll talk about, in blood plasma, and allow us to detect and measure Alzheimer's disease in living individuals. So many people still think that you can't make a diagnosis of Alzheimer's before autopsy, but that's not been true for some time. We make this with a lot of confidence now in using biomarkers. And let me tell you a little bit more about them. First of all, one big lesson that this field has learned is, to do research on treatment without biomarkers has been really difficult. Everybody is aware that we've gone a couple of decades without real breakthroughs in Alzheimer's disease treatment. One of the things that happened was, there's limits to how accurate your diagnosis could be without biomarkers. I consider myself a good clinician, but in the very best hands, there's at least a 15% error rate in diagnosis. There's also a lot of people out there with preclinical disease. So your control group that you think you're comparing to, about 20% of your control group is going to have preclinical disease. So when you have a messy treatment group and a messy control group, it ends up being really hard to prove something. Okay? So you need maybe 10 times fewer participants in the study if you could be absolutely sure that the treatment group has the diagnosis that you target and the control group doesn't. Okay? So I think a big advance of the last 10, 15 years has been the development of these biomarkers. And that brings me to ATN. There was one member of the audience who came in the door asking about ATN tonight, so I hope I'm addressing your question. So we use an ATN framework, at least in research, for diagnosis of Alzheimer's disease. And A stands for amyloid, T stands for tau, and N stands for neurodegeneration. So we can use tests for each of these three factors. So for amyloid, we can measure amyloid protein in the spinal fluid. We can measure amyloid protein in an amyloid PET scan. As I'll talk about, we can measure amyloid protein in an amyloid blood test now. Same thing for tau. And neurodegeneration is assessed with an MRI scan or a PET scan or even spinal fluid as well. And everybody can be classified on this ATN system as being, hopefully most of us here are amyloid negative, tau negative, neurodegeneration negative, ATN negative. But if you have a positive amyloid marker, those red lines, you're on the Alzheimer's continuum. Amyloid only accumulates in Alzheimer's disease. And if you also have a positive tau marker, you have Alzheimer's disease, full stop. And I haven't said anything about your cognition, have I? So you can have Alzheimer's disease in this framework with only the laboratory evidence of it. You could have dementia or mild impairment, or you might be one of these people in the latent phase who doesn't yet have detectable memory loss. The strengths of the ATN framework, first of all, is it sort of just defines the disease biologically. It just takes Alzheimer's observation, plaques and tangles causing dementia, and operationalizes this as, chemically we're finding the proteins of plaques and tangles, okay? And we can target that with interventions that are designed to interrupt amyloid or interrupt tau. And the other big advantage is now we have a way to go into the preclinical period and to divide people into those who have Alzheimer preclinical process and those people who just have normal cognitive aging, okay? So to study this in the preclinical area, you have to have biomarkers. So here's what happens then. So the red curve I'm showing you here is this exponential curve. And you can see along the bottom is age of somebody in the population. And the red curve is the rate of dementia at each age in the population. And you can see that it's pretty minimal until about age 65, and then it doubles every 5 years after that. It climbs up. The blue curve is the rate of a positive amyloid brain scan in the population. You can see it also has that exponential curve, but it starts climbing around age 45 and parallels the red curve just 15 years earlier. So that is the test that can show preclinical process happening. And if you look at age 70 there and follow that over to the y-axis, it's about 20-25% of us at age 70 would have a positive amyloid scan. So at age 70, a few percent of people have Alzheimer's dementia, but 10, 15 times that will have this preclinical process. So I think of it as like, dementia is the tip of the iceberg, and the action here is below the waterline in the people that have mild impairment or no impairment. And I think our challenge in medicine is to get to these people who have minimal or no impairment and start delaying the game there. And the way the math works out, if you could just delay Alzheimer's disease by 5 out of those 15 preclinical years, you would cut Alzheimer's disease in half. You'll cut Alzheimer's, penalty flag on the play, Alzheimer's dementia in half, right? That's our goal. So the amyloid PET scan that I mentioned, that's kind of interesting. The amyloid PET scan, by the time that someone comes in and sees us with mild cognitive impairment, the amyloid PET scan is already maximally abnormal. It's never a close call. You have a positive scan or you have a negative scan. And it doesn't seem to matter whether you have mild symptoms or mostly memory symptoms or mostly language symptoms. The amyloid scan is abnormal in the same way. As if the amyloid is accumulating first and is sort of like its insult and the brain is reacting to that a little bit later. And that seems to be the case when we look at the tau scans that we're now able to do that acts very differently. The tau scans are generally not positive until people start to have symptoms. And even at mild cognitive impairment, the tau scan is not reliably detecting that. And as the dementia gathers steam, the tau scan will track that. So we can use an amyloid scan to certify diagnosis, and we can use a tau scan to assess the burden of disease and maybe track prognosis in the future. So I tend to think of amyloid as the insult and tau as tracing the impact of the disease, if you want to think of it that way. Okay. Which kind of brings me to the third way that the amyloid and the tau are important to our discussion tonight, which is besides being a hallmark or a marker of disease, are amyloid and tau actually involved in driving the disease? Are they really part of the important biology of the disease, or are they just like bystanders that we see? And there's been this long-standing notion in neurology called the amyloid hypothesis or amyloid cascade hypothesis. How many people have heard of amyloid hypothesis? This idea that the amyloid protein is toxic to the brain in some way. So as it deposits and accumulates over the years, the brain is reacting to that and hand waving, nerve cells begin to degenerate. We're not sure exactly what the connection is there. The amyloid hypothesis has been has the strong version, which is it is the driver of disease, and has a weaker version, which it is sometimes the driver of the disease. I don't think the weak version of it has ever been really in question, but the strong version is something we're really wondering about. Is it really the only driver of disease? And the biomarkers that we're using are giving us a handle on this, and I'll return to this when we talk about the amyloid clearing antibody treatment that we're starting to get some experience with. We're not super happy with the biomarkers being available only in PET scans or spinal fluid. PET scans require, a whole medical apparatus to do. They're expensive and they have a lot of infrastructure with them. Spinal fluid measures are really useful, but how many people are really enthusiastic about getting a spinal tap? I spend a lot of time counseling people that this is a safe procedure and that we need to do this, but it's not really something people want to do, and certainly not something an asymptomatic person's going to be enthusiastic about. And then there's some equity issues too. In research, a lot of our underrepresented groups are less accepting of these kinds of procedures. And we end up kind of limiting our scientific possibilities if we don't have a better way to do this. So that's where the blood plasma tests come in. So these are relatively newer. I'm showing you some data here. Sorry, I have to show you a couple graphs. But this is showing how well an amyloid marker performs in the spinal fluid. And on the upper left there, you see the red dotted line at that level you can separate the people on the left are mostly above the line, the people on the right are almost all below the line. That's pretty good separation of your amyloid positive and negative groups. And that bottom half, that curve should look squared. That should look perfectly square if that's a perfect test. That's all you need to know about that. Here's how it looks like in blood plasma. You can see that the red dotted line in the top panel doesn't separate them quite as well. It does a good job, but it's not quite as good as the spinal fluid test and the ROC. Sorry. There you go. Sorry. Now you can see that the red dotted line doesn't separate them quite as well. And that the curve isn't really squared nearly as well on the bottom one, right? So that's how blood plasma amyloid tests are performing. Much better than anybody thought they could perform, because the amyloid has to get from the brain to the spinal fluid and then to the blood. But not quite ready for prime time in terms of making your diagnosis. Pretty good at excluding the diagnosis. We call that predictive value negative. It can be really good for this test. And so if your blood amyloid test is negative, you probably are safe. Okay, but if your blood amyloid test is positive, we have to follow it up with a better test. But even today, you can go out and there are companies now starting up to do this kinds of tests in a responsible way. And I think you're going to see this evolve a lot in the next couple of years. And then one slide to show that we also have blood plasma tests coming for the tau marker as well. Two versions of that are on this slide. Suffice it to say that these tests are technically easier to do than the amyloid test, and are probably the tests that are going to really gain a lot of clinical traction. We already use these tests in research settings for screening people and deciding who should get the expensive PET scans. As amyloid clearing antibody treatment is coming into clinical experience, you're going to see a lot of pressure and incentive, I guess is a better word, incentive to get these blood tests rolled out and to have a defined clinical role. So I think that's going to be one of the benefits of these new treatments, is besides creating a real strong reason to get an early diagnosis and an early intervention, it's also going to drive the technology and bring these biomarkers into the mainstream. So what we've learned about blood markers is, they're in small amounts, but the modern technology like mass spec really can measure them, and we're starting to see them getting FDA approval and being set up in what are called CLIA labs, which are labs that will take responsibility for this, for clinical decision making based on these results. We're hoping that they will find a role in screening and may become ready for prime time use in our clinical decision making in the next couple of years. So then amyloid clearing antibody therapy. So has anybody heard of some of these medicines in the news? If you have somebody affected in your personal sphere and you've been watching the news, you've picked up on this: aducanumab, lecanemab, donanemab. Now you see we're inventing medicines that we can't spell or pronounce. These are all, I would say, these are all medicines that are in the same class. They're all, in general, what we would call amyloid clearing antibodies. That means they're able to be given in a high enough dose that they will penetrate into the brain and be able to attach to amyloid protein, and then your immune system is your partner to pull the amyloid out of the tissue, okay? The one we'll talk about mostly tonight is lecanemab, or Leqembi, the brand name for that, which was fully FDA approved this summer and which Medicare has decided to cover. So that's a medicine that is not a cure, a medicine that is entering our armamentarium for treating people with mild Alzheimer's disease. And I'll talk about that in more detail. Aducanumab was in the news, is not been broadly approved by the FDA or Medicare, and I won't say more about it. It's probably doesn't have a lot of future use. I'm going to just hazard to say that. Donanemab, we'll talk about with one slide in a minute. That is coming. That's another treatment in the same class that we think is going to get full FDA approval soon. So back to what can you see under the microscope? Remember all the amyloid plaques we saw on that other slide. Everything brown here in this slide is amyloid accumulated in the tissue, and most of what you see there is amyloid plaque. And what we can show with lecanemab or donanemab, for that matter, is your amyloid PET scan after a year or 18 months of treatment will be dramatically changed by this medicine. In fact, your amyloid scan probably will turn negative, okay? So it does really remove amyloid from the brain. It's pretty remarkable. And the New England Journal paper, which presented the results of the clinical trial that led to FDA approval, made a big point of that. So there's a big reduction in the amyloid burden. There is also a better cognitive outcome. It's not as dramatic. You see the two curves don't separate as well for the clinical side as they do for the amyloid burden side. But you do see something in the range of a 30% slowing of decline. So there's decline, but it's slower. And I guess one way to think about this would be, look at that little red dot there that I put on the 12-month mark. And if you kind of follow that over to the treatment curve, that's about 5 months long on the x-axis. So out of that 18 months, maybe you gain 5 months on the disease, okay? So what do you think? Is that an important degree of benefit or not? I think people's opinions vary about that, right? And we don't really know what happens after 18 months. We will know because there's an open label follow-up that's happening. But we don't know if you get 30% compounded annually. How many would invest at 30%? Or whether you don't, or whether they just parallel each other at that point. We don't really know. But what we do know is that we've made a dent in the relentless biology of Alzheimer's disease because we pulled that amyloid out of the brain. And it turns out that the tau markers are also better. We usually think of that as a downstream impact, right, of amyloid. So in my mind, there's a benefit. Clinically, there's also a benefit biologically, so it's a good first step. So like I said earlier, Leqembi is not a cure, it's medicine. I've already made the point it slows but doesn't stop Alzheimer's disease, and it turns out it's not appropriate for everyone. And I'll explain that in just a second. Taking it as a commitment, Leqembi is an intravenous infusion that you get every 2 weeks for 12 to 18 months. Okay, so I have snowbirds who are worried about this, right? But not just snowbirds, people who live at a distance from our center, because we're going to do all the infusions right close to home for reasons that I'll explain in a minute. We have to keep track of this disease because there are some adverse effects that can happen, and we need regular MRI scans, and we need to be able to count on the quality of those scans. So I mentioned it's not for everybody. The clinical trial tested this in amnestic mild cognitive impairment, so that 5-year mild cognitive impairment phase, and very mild dementia. And that's a little bit up for grabs what that means exactly. But it's really for the mildest end of the Alzheimer's disease symptomatic spectrum. And you have to have a positive biomarker test, okay? Something that shows that there's amyloid in your brain. It's not approved for more advanced Alzheimer's disease, just wasn't tested. And we primarily are worried about the safety profile for more advanced cases. Now, when I showed you this slide a little while ago, I told you about all the amyloid plaques in there. If you look right in the center where the skinny arrow is, you see there's also a blood vessel, and that blood vessel wall is filled with amyloid. So amyloid also worms its way into the blood vessels, and the lecanemab is going to fish the amyloid out of the blood vessel walls too. So what's been described as a side effect is this effect on the blood vessels. I'd think of it more as effect than side effect because it's pulling amyloid out. But it causes those vessels to get leaky. You can see some fluid extravasate from the vessels, and you can see some small-scale hemorrhaging, what we call microhemorrhages. And in the MRI scans I have there, it's a convenient patient because the patient's got one hemisphere which looks pretty abnormal and the other one which looks more normal, but you can see all the white blotches which mark the extra fluid in the brain, and the little tiny black dots under the white arrow on the right that show the little microhemorrhages that are happening. So these are called ARIA, or amyloid-related imaging abnormalities, and somewhere around 15, maybe 20% of patients who take lecanemab are going to develop some degree of this, mostly asymptomatic. So we have to track it down with an MRI scan periodically to survey for these effects. But you can have this as an adverse effect. That's why you should think twice, okay? But the good news is that with that kind of monitoring, almost everybody, 93% or so of people who undertake lecanemab will be able to finish the course safely of the medicine. So that's a narrow balance of benefit to risk. We have to be careful about who we select. We can't enroll people who have blood thinners on board, for example. You have to be able to have MRI scans. You can't be claustrophobic or have a pacemaker that prevents you from having MRI. And we have to closely coordinate infusions and surveillance. But as I mentioned, when we do that, we think this is safe enough for clinical use. The one thing that a talk like this can't tell you is whether lecanemab's right for you. That's a decision between you and your doctor. There are a lot of factors to consider. Some of them we've already talked about, the medical factors like, where you are on cognition, right? Is it mild impairment or do you have more marked dementia? What your brain scans and biomarkers are saying, and your individual health, including your medications. But there also are factors that depend on the patient's point of view. How do you weigh that degree of benefit against the risk and cost and commitment that it is for this treatment? How well Medicare and your other insurance carriers are going to cover you. Not everybody's on traditional Medicare. There's Medicare Advantage people out there. There's the secondary payers haven't all weighed in on this. There's still a lot of questions. How easy or hard it is for you to get to the infusion center. All these are important factors. But we're excited. This is the first kind of disease-modifying treatment, and we can bring it to our patients safely. It's going to increase the value of an early diagnosis, as I said a little while ago, and it's going to drive the availability of these new biomarker tests. So we hope this is just like the first foothold on Alzheimer's disease. And the hunt is on, for a version of this that doesn't cause ARIA. To me, this is like the AIDS story. You remember AIDS? I don't know if people remember the late 80s when AIDS was a death sentence and AZT came on the market and it was toxic and it had this much benefit but the hunt was on for a non-toxic version, right? And pretty soon you had combination therapy and made a real difference for the disease. I think that's the right model. It's going to be an incremental improvement. You can expect more convenient biomarkers are coming. You can expect more flexibility in the infusion options. Eventually, I think home infusion is a realistic thing. I think there are companies that are vying for putting that in place. And eventually, expect us to be able to use biomarkers to guide the duration and the completeness of the treatment. Maybe people don't need 18 months of treatment. Maybe they need treatment up to a certain biomarker result. And then I mentioned donanemab. So donanemab is another amyloid-clearing agent that we expect will get FDA approved. The graphs I'm showing you right now look almost identical to the ones that were presented earlier for lecanemab. So it's got the same sort of credentials. Big-time amyloid clearing, modest clinical benefit. The donanemab paper does make it clear that the tau markers are systematically better in the treatment group. I believe that's true for lecanemab as well. I think it's a little bit like Moderna and Pfizer, Okay, they're a little bit different, but when you get to the front of the line, you probably should use the one that they have, right? Just saying. Anyway, so I think practice is going to evolve. If you are interested in the latest, our latest take on this, you can look at our webpage at uwmemoryanbrain.org, and we maintain a lecanemab page, which is up to date. There's a webinar, a canned webinar aimed at patients on that site that you could watch and get a rehash of what I've just said and maybe a little more detail. Okay, and then just a couple words about the future. So I think the future is here. I think the future is we're going to remove diagnosis even earlier. If you think about what we're going to do in 2030, we're going to first see whether these amyloid clearing agents or other agents are making it possible to postpone the onset of mild cognitive impairment. So there's a study going on right now called AHEAD, using the same lecanemab medicine, but instead of in mild cognitive impairment, in preclinical epic, okay? In a few years, we'll know, is lecanemab delaying mild cognitive impairment? Then there's a great reason to get that blood test when you're 60, see if you're amyloid positive, and see if you can sort of redshift everything so that your mild cognitive impairment or dementia gets pushed so far out that something else gets you first, right? Okay, basically. But we move disease-modifying medication into the preclinical, and so we really talk about prevention of cognitive impairment. Because after all, that's what we want to do, spend more time in, functionally independent. Whatever's going on biologically inside the head, you want your function to be good, right? if you're HIV positive, fine, as long as you're living a productive and high quality life. There's a medicine behind the scenes, that you take, but you keep it at bay. I think that's the right model. So I'm going to wrap up there. I'm privileged to speak on behalf of my whole team in the UW Medicine Memory and Brain Wellness Center, where we envision a world in which people live well with memory loss within a community of support. Maybe I'll leave this up for a couple minutes if you would like to take down our web addresses there on the bottom of the slide, or look at some of the opportunities to participate in research or reach out to us. So thank you very much for your attention.
Thank you, Tom. That was great. I'd like to also invite now Sylvia Russo up to the podium. Sylvia is a local neurologist. She did her medical school in Milan and came over here. She's done extensive training at UC San Francisco and then at Stanford before coming to the illustrious Inland Northwest. So before we get to questions, I'd like to see if Sylvia has any questions or comments that you'd like to make about the talk, and then we'll go to a question and answer period.
Hello, everybody. Thank you for having me. And this was a really good lecture, really good overview. And so I am happy to be here. Again, just new here to the area, past a year and a half. We are a small clinic, but we're filling a large need in our population and in our community where there wasn't a whole lot of memory neurologists before I arrived, and so a big lack of diagnosis and a big lack in the understanding of this disease, which is so common and it touches so many, as we've seen by the raise of hands before. So we're mainly focused on the basic clinical work of making the right diagnosis, giving the right advice, and putting the right resources in. And any questions that come along, please let us know, and I'll give you the microphone back.
Okay, thank you. Kim is gonna has some microphones. If you have questions, please step to the aisle. And while she's doing that, I will start off with one question for both of you regarding lecanemab. And just knowing some of the prior literature showed perhaps an improvement with cognitive testing, but maybe not perhaps noticed by caregivers or others. So the improvement in cognitive status with the new medications, are they clinically meaningful, and do caregivers know it, or is it just noted on formal cognitive testing?
I'll take the first crack, I guess. Hear me okay? No. How's that? Better? Okay. So first of all, the primary outcome in these trials was a functional outcome, not a cognitive outcome. So it's what we call CDR sum of boxes, which is a measure of your daily functioning. And it's a little bit interesting because by selecting patients who have mild cognitive impairment who aren't very functionally impaired to begin with, there's not a lot of improvement, not a lot of room there. So yeah, it's in terms of the absolute level of functioning, very modest, but then again, what do you expect when the diagnosis is mild cognitive impairment? So I take the conjunction of the right direction on cognition and function and the really dramatic right direction with the biomarkers to be encouraging. I think it's the first step.
Yeah, I don't know if this works. I concur with that. The CDR is a weird measure, and we talk about it a lot in our clinic because the question obviously comes up from patients. And there are some experts that say that to see a big difference in somebody's function, you would see a CDR change of 1 point or more. And when you look at the trial results, they show a difference of 0.45 points. So that's about less than half a point. And some experts say maybe that's not enough for a family member to say, oh, the person is much better now. So that's the big question mark. It's definitely encouraging that change is happening. When I went into medical school, this was the field nobody wanted to go into because there wasn't any big news, you know? And so it's exciting and it's encouraging, but maybe there is a lot more work that needs to be done to get to that point where we make a big change for patients' lives. But definitely the first step.
Yeah, first, I have a question about, you finished 18-month treatment and you took the amyloid and maybe some of the tau out, and the processes in the body that put it there in the first place have not been interrupted. It didn't just sneak in there, we know that. Can you address possible biomarkers and interventions to interrupt earlier in the process rather than hauling this stuff out after it's left there at the end of a probably chronic inflammatory process? Maybe interleukin-6, high-sensitive CRP. There's different ways to look at inflammatory markers and other earlier processes.
Yeah, I mean, it's a $64 billion question, right? What are the earlier upstream problems? No one is thinking based on these data that amyloid's irrelevant, but no one's thinking it's the whole story either. This 30% improvement, that might be everything that amyloid causes. The rest of it might be inflammation and tau and other stuff. We don't know. I think so I'm just going to back up. One really interesting history here, which we didn't mention, is back in the late 90s, someone had the idea maybe you could vaccinate against amyloid. Maybe you would never accumulate amyloid. It worked in the mice, and it got rushed into human trials, and it was a disaster, right? It caused something like ARIA, but worse than ARIA. Now that a passive immune strategy is having some traction, maybe there's some value to thinking about, is there a way to do that? Will the vaccine be revisited eventually? That's an interesting question. Yeah.
Can you hear me?
Yeah.
I was diagnosed in 2011 with MCI, and I don't know if it's gotten progressively worse, but my question is twofold. Number one, are we going to be tested on this? No test?
No.
Not tonight? Okay. Lighten it up a little. My question is this. I've kind of felt like I've gotten a go-around around the tree or the block. I started reading about the Leqembi 6 weeks ago. And I think I'm in the very early stages. I think MCI is what it was diagnosed in 11. I'm not sure if it's gotten any worse. I don't think it's certainly not Alzheimer's. I need to know the procedure, because I was told by Dr. Russo's office, I believe, to talk to University of Washington, and I did. I called over there, talked to a young man, said, we can't do anything until you send me your medical records, which I did a month ago, and I haven't heard anything. Is that the way I should go, or should I go back through my doctor who, he doesn't know a lot about what's going on?
So I've been asked to repeat the questions for the benefit of the rest of the audience. So the question has to do with access.
Procedure.
The problem has to do with procedural access for either lecanemab specifically, yep, or for evaluation and appropriate management of mild cognitive impairment.
Both of them.
Yeah.
Yes.
So yes, this is an issue that we have limited capacity. The procedural way to do that, there is a number there. You should be able to call that number and get an appointment, or get the process of medical evaluation of your in Seattle. So, and I'll let Sylvia talk about what she can do. I think we're all finding that there's going to be more demand than we can easily accommodate for this. You're seeing a system kind of spooling itself up. We're actually starting the lecanemab infusions next month, so there's a lot of infrastructure to put in place.
What I've read about the leukemia can be a preventative, is that correct?
We don't know that, no. So
Somewhere in
the question is lecanemab preventative? Lecanemab is right now indicated for people who are already symptomatic, but in a mild degree. We don't know if it will prevent symptoms given earlier.
Okay.
That's research. Yeah.
Somewhere I read that. I don't know whether it was in the newspaper or not.
Yeah.
Sophie, do you have comments on that?
Absolutely. So thank you for bringing this up. And it's a really important question, and it's the first question that came to my mind when these drugs started getting approved. How are we going to get it to everybody who qualifies in time, because this is, as you're saying, a progressive disease. Some patients progress faster, some progress more slowly. In general, having the right diagnosis, having the biomarkers available, that accelerates the process. And correct me if I'm wrong, but I think having the biomarkers available beforehand will accelerate you actually qualifying if you're one of the few people in the right stage, And so that's kind of the goal of the community clinic or the community clinics around the country, to kind of try to get to that diagnosis clearly, or as clearly as possible, and trying to rule out all the contraindications. The thing I want to keep in people's minds is that there are side effects, and those side effects, true, asymptomatic for the majority, but it's still brain swelling and it's still brain bleeding, which if you stop and think, it's really important to try and make sure we minimize as much as we can. And that initial assessment really tries to look at all those factors. Could this person get it or not,
And I think those are all great points.
I have a quick. Our question is about etiology, what causes it. You did a great job of correlating symptomatology with amyloid. The question is, what's causing the amyloid? I think back about peptic ulcer disease, and there's a lot of correlation with symptoms and sizes of ulcers and treatment with the pyloroplastic vagotomy, but it really wasn't until it was proven by Helicobacter. So what's the etiology for causing the amyloid and a tau?
So yeah, this is a great cautionary tale, because I was in internal medicine in the late 1980s, and I was treating these patients with peptic ulcer disease too. And you would never have gotten me to believe that there was a bacterium responsible for this, but there is. Yeah, so I think there's a lot to be discovered about what are some of the early events, but the idea that amyloid has nothing that it's not causal, I don't at all. I think that is pretty easy to refute, because all you really need to know is, like, for those rare families in the world, and the only genetic abnormality they have is one extra copy of the amyloid gene, and they all get early onset Alzheimer's disease. So that's enough to do it. Is that what happens? Is amyloid responsible in all cases? I don't think so. I think we're going to be talking about Alzheimer's diseases, and there may be other ways to trigger that final phenotype of plaques and tangles in the brain. So it's a good question, and it's more than we know. Actually, I can't tell you there isn't a microorganism that could cause it. There's some smart people that think there is, actually.
I agree with that, and there is a lot of work trying to look at what oxidative factors, what immune factors could prompt the increased aggregation of amyloid not just the plaques, but the smaller forms, those fibrils and protofibrils. And it's still all up in the air, to be frank. It's really, nobody knows just yet. But there's work aimed at that, and also aimed at how do we reinforce the oxidative pathway or antioxidative pathways or immune regulating pathways, but there's nothing definitive yet. This is a really, really tough disease to crack, especially at the early stage, because remember, when it starts, nobody knows. You're asymptomatic, and so that's the big conundrum for this disease.
You know, one of the things that strikes me is I can be a simpleton at times. Bleeding in the brain is always bad, not a good thing. And so do we know enough, are we doing subset analyses to know who might be at higher risk for the complications of bleeding in the brain when exposed to these meds?
So one factor that we know is influential is your genotype for apolipoprotein E4, or ApoE. So many people have heard of ApoE as a genetic risk factor. It's not, so it's about 15% of us carry the E4 allele, but more than half of Alzheimer patients do because it's that strong a risk factor, okay? For the first time, we as neurologists are going to have to start systematically testing this in our patients because it does influence your risk of ARIA from lecanemab, and especially the people who get E4 from both mom and dad who are homozygous for E4, there's a higher risk of bleeding that's going to happen. So we have to track that. So that's new for us. It doesn't absolutely contraindicate it, but boy, it's going to influence the conversation. Yeah.
Yeah, and I agree with that, obviously, and I add that we still don't know who's going to cover for this genetic test. And sometimes the counseling that has to happen before we take the tests, and that's still all brand new. And so the differences between when the FDA approves a drug and then how do you actually implement it in practice. I would want my patients to take the genetic test before they enroll in something like this, because it does again, influence your risk, and it does influence what you may end up deciding whether to do the drug or not. And so we really need clarity as to which insurance is going to cover it, how much of it are they going to cover it, can we as doctor fight with the insurance for them to cover it, We still don't know, and more to come in upcoming months probably.
So my question had gone to the ApoE risk factor as well, and which you pretty well covered. But the other part of the ApoE question is that ApoE2 is protective against it, and that the likelihood of getting the Alzheimer's when you carry the ApoE2 allele, then is there a way to be able to use even that difference between ApoE2 and ApoE4 in terms of being able to predict whether these medicines are going to work better? Do they play a role in the buildup of the plaques? Because, I mean, they are lipid transporters, so are they part of the plaque buildup?
So one thing I always remember when I give a talk in Seattle, maybe in Spokane too, there's always somebody in the audience who knows more about some of this than I do. The question is about ApoE4E2, ApoE2 allele, which is possibly somewhat protective against Alzheimer's disease. The problem is it's very infrequent. Not many people have E2, and even a fairly big study like this that supported lecanemab isn't going to have enough information in it to make an assessment about how E2 is really influencing risk. One thing that we didn't mention is another thing that's new to us is that anybody gets treated with lecanemab, the Center for Medicare and Medicaid Services is requiring us to enroll in a national registry to keep track of what this is going to do in the real world. And at that level, the numbers might get large enough to answer your question. but we don't really know the answer to that.
Yeah, a question about what we can do in terms of influencing what kind of support is available and what kind of role a government or other organizations can play. What can we do in terms to influence that? Who should we contact? Who should we write letters to? Who should we encourage to support your efforts?
So yeah, so the question is about what can citizens do to help us push this field forward? You know, our big champion has really been the Alzheimer's Association. So I don't know if there's someone here from Alzheimer's Association tonight, but the Alzheimer's Association has done a wonderful job of advocating for increased levels of federal funding for research, for some of the legislation around support through Medicare for caregiving, for case management. More services are going to be possible in future because of the advocacy. So you might look at supporting your friendly Alzheimer's Association and entrusting some of your support to them, if you will. You know, if your concern is about specific research directions and things that, you know, people presenting are doing, then you can talk to us. But at a policy level, I think Alzheimer's Association is the easiest way to do that.
I just want to say that we have we're live streaming this, and we're not getting any questions from the people who are viewing online. If you do have questions, please type them into either the Q&A or the chat, and we will be monitoring those and trying to answer your questions. With that in mind, there's a question in the back.
Sylvie, where do you work, and are you accepting new patients? Because I have some people that I think need to probably be referred to you.
So this is my colleague Jenny out there. So can you repeat that? I didn't hear it.
I know Sylvie said she works in Spokane. Where do you work, and are you accepting new patients?
Okay, so the question is for me. Yes, I work at Providence, kind of in the outpatient center, formerly known as Doctor's Building. I think that's the name that people most commonly relate to. And yes, I am accepting new patients. I'm the only provider that is the only behavioral neurologist, and so patients have had to be very patient with me in terms of the wait list because we're trying to accommodate everybody who doesn't have a neurologist already or who doesn't have a neurologist readily available in their system. I would like to emphasize that, as I said before, we are a clinic, a community clinic, and we focus on the more established kind of care and treatments. We are not doing clinical trials just yet because I think that when you're tasked with a community that doesn't have other or many other memory neurologists and without a tertiary referral center that's so close, because the closest is the University of Washington in Seattle, and the second closest is the Mayo Clinic, you really have to focus on giving patients the right diagnosis. When I came, and still to this day, there is a lot of confusion about, you know, what is my diagnosis even, and that's not always very easy, you know, and so that's our focus, is mainly clinical, but that also helps facilitate access to more advanced treatments, which are to be done through tertiary referral centers still. Not sure if I answered your question or any other questions.
Yeah, I was wondering if there's going to be a memory hub in Spokane, and if not, if there's any way to get something like that to come here.
So the question is there going to be a memory hub like we have on First Hill in Seattle, in Spokane? Great question. You know, I know this isn't a totally satisfactory answer to you, but one of the blessings of COVID was how much it normalized telemedicine and Zoom and remote access to resources, and a lot of what we do is accessible, and we do plan to disseminate through that channel. Is Mary Grace Becker's name is up here somewhere? Top line, Mary Grace Becker. She would love to have that question from you. She's our leader of the Memory Hub, yeah.
Hi, Dr. Grabowski. I would like to know if there is any effect of lecanemab in the tau tangles. I was wondering, since amyloid builds up earlier and tau tangles normally after, and they are more often related to cognitive decline. So I don't know if there is any data on the effects.
So the question is, what about the effect of lecanemab on neurofibrillary tangles, established neurofibrillary tangles? I don't know if the lecanemab data address that very satisfactorily, but I was reading over the donanemab paper, and so this I think would be probably be similar. The tau PET scan, which we think indexes tangles, is not changing much with donanemab. It's not. The soluble tau measures, the plasma, like the blood plasma tau measures, are improving, but the tangle burden does not seem to be changing. Take what you will from that, but I do think that the tau tangles are marking, the degenerated systems, yeah.
If I can, just one more question. In relation to the population, I heard that lecanemab was studied on majority white population, right? So I'm wondering if the effects in other populations, in other races can be different.
Yeah, so what about underrepresented groups in research? So there's an enormous effort to try to correct this overrepresentation of well-educated Caucasian people in clinical trials. And, I think donanemab did better in enrollment that way, but there's that's a great question. We do know there is disparity in terms of incidence rates of Alzheimer's disease in people of color. African Americans, Native Americans in particular, have higher rates. Yeah.
Okay, can you hear me okay? Okay, I just want to start by thanking you all for coming over here and giving this wonderful lecture. It's really wonderful you opened it up to the community. I wanted to follow up more on the cognitive training that you recommended, especially with, it sounds like kind of limited access to neurologists in the Eastern Washington area. What kind of cognitive training do you guys focus on, and how long do you typically implement it, and how do you recommend individuals in our area to access that?
Do you work on that? Do you want to take first crack?
Yeah, so we usually refer to our colleagues in speech therapy or speech and language pathology. Typically, I refer people who are still in the early stages. A person with more advanced dementia may get frustrated. Having said that, if the person is willing to participate, then I also refer maybe in more advanced stages. People sometimes get confused because they ask me, why are you referring me to the speech pathologist? I can speak. But this particular branch of rehabilitation has the added experience of this, what we call cognitive rehabilitation. It's not for everybody, but it tries to focus on the strength and the interest of the individual, and trying to devise ways to work around some of the cognitive difficulties. And kind of come up with a plan that focuses on the person themselves and trying to bypass their most common frustrations. It doesn't help everybody, it's not for everybody, it's not a cure, but some people have showed some benefit with it in the sense that they're now have a tip or a tool or a strategy to kind of work around some of these symptoms. And so that's what I generally do when people are motivated enough to both go to the appointments and also do the exercises at home. There is a lot of brain apps about, mind training and exercises. Those are really not well validated. Having said that, if it's something that spurs your interest, it's still cognitive activity, and we've heard already how important that is, those 3 hours a week, So I still encourage that, but it's not necessarily something that's validated to improve symptoms by itself.
I would add maybe a distinction between sort of restitution or sort of a training somebody who's like not very impaired versus compensation in someone who is impaired in a channel. So there's two different things. And I agree that a lot of the software that you see out there for brain games, brain training has not been well validated. When we have used something like, recommended something like that, we've recommended the tools that come from Posit Science, something called Brain HQ, which does have some research basis behind it as opposed to just marketing effort behind it. But on the other hand, there are other ways to think about cognitive engagement. So decision-making in a social context. I sometimes tell people, go find something to volunteer on, help people in a group solve some problems. That's just as good, maybe better, because it gets that social connectedness piece in there. But the fine-grained science about is this approach better or that approach better has just not been done. Yeah.
All right, so thank you all very much for coming this evening. I don't know about you all, but this is the first time in years I've really felt hopeful about this disease. And I hope you all feel that hope as well. We're going to be making the diagnosis early. We've got some tools now. So I hope you all feel that way. Hope you all came away learning something. Thank you, and please give our speakers another round of applause.
I guess I'm going to put it back on.
Oh, okay.
Yeah, you can probably put yours.
Thank you, Sylvia.